So today, Dr. Scholz, we're talking about testosterone replacement therapy, and we have a previous video that kind of goes through the ins and outs of it, but today we're specifically talking about it in advanced categories. So when would testosterone replacement therapy be appropriate?
Advanced categories, of course, we're talking about men that at some point along the way have been shown to have metastatic disease. A lot of hormone therapy for newly diagnosed men is appropriate, and we know that that's only going to be given for a time period, and then we're going to stop it. Our conversation previously was about those men that were given Lupron and their testosterone never really appropriately recovered. For advanced, it seems very counterintuitive that we would take someone who perhaps is in remission with an undetectable PSA, who had proven metastatic disease, and allow them to have testosterone. The concern is that we'll ignite sleeping cancer, create cancer progression, and early mortality. As counterintuitive as it is, there are studies showing that this can be safely done as long as you don't let things run too far. In the intermittent studies that are published, people were allowed to have their PSA rise due to cancer growth, known cancer growth, with PSA rises up to 5, 10, 15, and then with the resumption of hormone blockade and taking testosterone away, they go back into remission again. The idea of giving testosterone to these people is really fundamentally no different than allowing people to stop their Lupron and have their testicles make testosterone. So whether the testosterone is coming from a testicular source or whether it's being administered exogenously with a cream or a shot, it's the same exact thing. So if it has been proven safe to stop Lupron and these medications in men with advanced disease, it clearly would be safe to give testosterone if those people aren't spontaneously recovering their testosterone, because it's basically the same thing. Basically means that it is safe to consider taking testosterone in men who have had metastatic disease in the past if they're trying to recover their quality of life, and if they're willing to deal with the uncertainties of a rising PSA, which is a little unpleasant. People equate PSA with growing cancer. And it is true that some men tolerate low testosterone levels quite well, and for them, quality of life is keeping that PSA at 0. And I understand that. So the motivation to give testosterone is not to restore life or impute longevity to these people. It's just to give them a better quality of life. And I think that's a personal decision for each individual. What's more attractive, having some testosterone back or keeping that PSA at 0?
I just wanted to take a quick moment to remind you that all of the videos that you see on this channel are sponsored 100% by viewers like you. So if you can go ahead and donate, that would be great, and join us in our journey to get prostate cancer education all around the world. You can visit our website pcri.org/donate if you would like to do so. Now back to this video on testosterone replacement therapy and advanced disease. So in your experience, when you've had patients who have had metastatic disease and now they're considering, or maybe they are taking testosterone, for the concept of the PSA to rise, is there like a common timeline of, okay, when 6 months we expect it or we're not going to expect it at all? What would that look like?
Well, there's a couple really, I think, advantageous things about allowing testosterone to come back or administering testosterone, as we're talking about in this video. Many of these men with metastatic disease may have had their metastatic sites radiated. We're finding that some of these men are cured, and you'll never discover that if you don't take a chance and allow testosterone to come back. In other words, we embark down a pathway of stopping Lupron or giving testosterone, and their PSA never does come up. So that is a possibility. The other argument in favor of stopping hormone therapy or administering testosterone is that with these powerful new PSMA PET scans, we're able to detect the site of PSA production now with great accuracy. We never had that opportunity before, so we would just let the PSA rise up. Yeah, you do scans, but you'd never find anything, or you quite commonly wouldn't find anything. And then you'd put them back on the testosterone deprivation therapy. But now we can find metastatic sites with PSAs less than 1 and ask our radiation colleagues to eliminate these metastatic sites. And some of these men are going into durable remissions. without any further hormone therapy. So I think with the advent of PSMA PET scans, the idea of administering some testosterone and trying to find where the cancer is, if it does come back, could potentially be a better approach than just sitting interminably on a low testosterone and continuing hormone therapy indefinitely.
When it comes to metastatic prostate cancer, there's oligometastatic, which is less than 5 metastatic sites, and above 5. So for testosterone, the concept of replacing testosterone in one's body, would that only be for the category of people who are in the oligometastatic category? They've only had a couple of sites, or could it be for somebody who's had more than 5?
Well, for us, doing intermittent therapy or adding testosterone is reserved for the patients that are able to achieve an undetectable PSA. It's interesting that in the intermittent studies that have been published, that was not always stipulated as a requirement. To my way of thinking, we don't want to be giving testosterone to men who have what we call a partial response. In other words, they still have detectable PSA. The disease hasn't been controlled. And I know that it doesn't answer your question directly about more or fewer than 5 metastases, but in principle, we're treating a systemic disease. And if there's uncontrolled disease, I'm not thinking of giving those individuals testosterone or stopping Lupron. But assuming that in a person who's had more than 5 metastases, that you've been able to get an undetectable PSA, our policy often in these people will to get a PSMA PET scan and see if of the innumerable metastases that they started with, are only a few of them still functioning or still have viability with PSMA PET scans. At that juncture, consider radiating those fewer spots. We don't think it's safe to radiate men that have more than 5 spots because you just get too much radiation. And there's a belief that maybe you're not really moving the needle that much in your anti-cancer therapy. But if the number of spots that are active with hormone therapy, maybe even chemotherapy, have been reduced to less than 5 spots, then is this kind of a back doorway into oligometastatic disease, and can we justify giving radiation? There aren't any real studies to prove or disprove that theory, but we do know from experience with experienced high-level radiation therapists that these spots can be treated essentially without toxicity, and it is covered by insurance. So I think it's an attractive way to try and keep the pressure on these cancers, and then if we can eliminate the few remaining hotspots, now that they've been reduced to less than 5, perhaps that's beneficial. So ultimately, the answer to your question is that when people, whether it's more than 5 or less than 5 spots, there is still a consideration for taking a holiday as long as the PSA has become undetectable while they're on the hormone therapy.
So in that situation, does age ever come into play that you wouldn't give it to maybe an older patient or a younger patient?
Well, I think everything we've said so far is predicated on the assumption that you've got a younger patient who's going to be living a long time. In older men, the possibility of using milder hormone treatment like Casodex and just temporizing is an attractive consideration. Many of these older men are not sexually active. They're not trying to recover their libido. You can keep the disease in check for many, many years with one Casodex, one bicalutamide pill a day, and it's convenient and effective.
What does the monitoring process look like in somebody who does have an undetectable PSA, they've had metastatic disease, it's controlled, and now they're deciding to take testosterone replacement therapy? How often are they going to need to get checked? Do they need to get testosterone checked every time? What would that look like?
The general rule of thumb that we have, if someone's had an undetectable PSA, let's say they've been on Lupron, and we're embarking upon a time period to stop that treatment, we'll typically give that individual an opportunity to make their own testosterone. We'll wait 3 to 6 months. We're checking PSA every 3 months along with testosterone. And if the testosterone levels don't rise spontaneously after 3 to 6 months, then we discuss the possibility of administering some testosterone. And if that is done, then we continue to monitor PSA levels and testosterone every 3 months. We're also monitoring, sometimes even more frequently, hematocrit, that's red blood cell levels, because if men receive testosterone exogenously through a cream or a shot, certain individuals will make too many red cells. They'll develop something called polycythemia, and this can predispose to heart attacks and strokes. So people have to be monitored closely for a high hematocrit, anything over 50%, and then back off on the testosterone doses, or donate blood and remove excess blood with a process called phlebotomy to make sure that their red counts are maintained in a safe range.
So besides the high hematocrit, are there any other side effects that the patients could experience?
High hematocrit is the one dangerous aspect, I suppose, if someone completely missed out on monitoring PSA, and could be a problem, but that's not going to happen. But in general, all the other, quote, aspects of testosterone are very favorable. Can you have a little fluid retention? Occasionally, no. Usually blood sugars are better controlled. If men have diabetes, they require less insulin if they're taking testosterone. It certainly helps build muscle mass, stabilizes mood, helps hot flashes to go away. Lots of very attractive things.
Another term I've heard is bipolar androgen therapy. Can you explain what this is and what the application would be?
Yeah, this comes up a lot because there are studies showing that certain subgroups of men with prostate cancer can actually respond, that is, have a reduction in PSA with the administration of testosterone. And what people forget is there are many different stages and types of prostate cancer, and this is only applicable to a very narrow segment of men with prostate cancer, those who essentially have run out of options. They've got widely metastatic disease, their PSA levels are rising, they've already had chemotherapy, they've already had Pluvicto, they've already been through all the sensible options. In that group, when you give testosterone, a small percentage, maybe 15% of men, will have some regression of their cancer, which is pretty exciting. The problem is that there's some other men that it'll cause the cancer to grow more quickly, and then there's a large group of men where it has no impact at all. That possibility of getting a response to high-dose testosterone is on the table as a consideration in men with the very most advanced types of prostate cancer that are resistant to all other known therapies. Thankfully, we're not seeing that category of men as much as we used to, but it is one of the treatment options to be considered. That same effect is not observed in any other stage of prostate cancer, so it's not something that one can argue if you have a low testosterone and we give you testosterone that that's a way to keep the disease in remission. That's not at all true. So it's really only that exceptional case for men with very, very advanced prostate cancer.
Today we talked about advanced prostate cancer with metastatic activity specifically, and testosterone replacement therapy. The main thing I want you to know about this is really the concept of quality of life and shared decision making. Maybe some of you are not happy with your current circumstances of how you feel on a day-to-day basis and you would like to see a change. I just want you to know that this is a possible option. All of the information here in these videos is really to empower you to have better conversations with your physicians and your medical team so that you can have a better outcome. And if there's something that's really bothering you, maybe there is a solution out there. If you do need help specifically, you can also visit our website, PCRI.org, and talk to our helpline team. They have information, not advice, but information that can help empower you for those conversations with your medical team, and maybe they can open you up to something you didn't know about before. Also, please remember, we're a 501c3 nonprofit, so if you would like to donate, that would be great. We produce videos every week, as you've seen, on prostate cancer, and we would love for you to partner with us in that journey. Most of all, I know I say it every week, but I really mean it. You're not alone. I know it's overwhelming, but you're doing great. I hope you have a great week, and much love from us.